Welcome to today's webinar presentation by Dr. Osama Hamdy. My name is Michael Montalto. I am Senior Director of Medical Affairs at Metagenics. Today's presentation is part of the Take Control webinar series featuring Dr. Osama Hamdy. Dr. Hamdy will deliver 5 Take Control webinars on the role of nutrition intervention and lifestyle modification and will provide practical approaches for sustained and improved health outcomes for the diabetic patient. Dr. Hamdy earned his medical and doctoral degrees from Mansoura Faculty of Medicine in Egypt and his fellowship in endocrinology, diabetes, and metabolism from the University of Missouri and Harvard University. Dr. Hamdy is a fellow of the American College of Endocrinology and is currently the medical director of the obesity clinical program at the Joslin Diabetes Center in Boston. Dr. Hamdy is also director of inpatient diabetes management at Joslin and an assistant professor of medicine at the Harvard Medical School. Dr. Hamdy was a member of the Nutrition Guidelines Committee of the American Association of Clinical Endocrinologists that developed guidelines for Americans in 2006 and chaired the task force that developed Joslin's clinical nutrition guidelines in 2011. Dr. Hamdy was a co-investigator of 2 landmark applied clinical research studies, the Diabetes Prevention Program and the Look Ahead trial, evaluating the long-term effects of lifestyle intervention combined with nutrition strategies to improve health outcomes in diabetic patients. Dr. Hamdy translated the clinical research results of these studies into a clinical practice model through the creation of Joslin's Why Wait program. Please join me in welcoming Dr. Osama Hamdy for today's Take Control webinar.
In the previous 3 webinars, we discussed in details the macronutrients that we consume every single day in our meal composition. And we explained why some of those macronutrients need adjustment and the impact of this adjustment on blood glucose level and also in body weight and in many of the risk factors for coronary artery disease. In this webinar, we will discuss the medical nutrition therapy for prevention and management of diabetes. So before we start, we would like to agree on the definition of medical nutrition therapy. Medical nutrition therapy is the use of nutrition as therapy, as medication, to improve health and quality of life. If you need to implement very good medical nutrition therapy, you need first evaluation of the nutrition status of your patient. And then after that, you will give your patient advice about lifestyle management, the use of medical nutrition in a very efficient way, in the right macro composition, in a meal plan, and finally, you will discuss with them if they need a specialized nutrition formula or not. Again, medical nutrition therapy can be from natural food, can be from specialized nutrition formula for calorie supplementation or calorie replacement or a combination of both. That's what you will do for your patients if you are aiming to implement a very good medical nutrition therapy. Major associations are advocates for the medical nutrition therapy. You can see the American Association of Clinical Endocrinologists recommend the medical nutrition therapy for prevention and control of diabetes. And they are encouraging that intervention is done through a registered dietitian. The same is the recommendation of the American Diabetes Association. They recommend that qualified dietitian or a qualified physician who has good knowledge about medical nutrition to implement the medical nutrition therapy. The American Diabetes Association think that medical nutrition therapy improve outcome and also reduce cost of healthcare. If we use medical nutrition therapy, we have to put in our mind that it has been shown in clinical trials that medical nutrition therapy can prevent diabetes in high-risk population. If it is used in patients with diabetes, it will help them to control diabetes and also reduce the deterioration in glucose control over time. And then if you use it in someone who has diabetes for long duration, you may be able to reduce the risk for complication, micro and macrovascular complication, and even you reduce the risk of mortality. So let me now move to the best knowledge that we have right now, the evidence-based knowledge that we have right now, that will guide you to implement an optimal nutrition and lifestyle intervention plan for those people who are overweight and obese, with diabetes, with pre-diabetes, or those at high risk to develop diabetes. I mean by people at high risk to develop diabetes, those people who are obese and have family history of diabetes, have dyslipidemia, have hypertension, have a history of gestational diabetes, or those people who have a history of polycystic ovarian disease, PCOS. In general, this population are very high risk. Maybe they develop diabetes or not. And your effort here is to help those people to lose weight. And the recommendation is that they will lose more than 5% of their initial body weight. It is optimal to achieve and maintain 7% weight loss. It is advisable if we can reach 10% weight loss. But the most important is that how we can maintain that weight loss for long duration. And we will discuss this in much more details in the last webinar of this series. What about macronutrients? From the previous presentation, it looks like it is safe to give your patients carbohydrates at about 40 to 45% of the energy intake. Giving carbohydrates more than 45% is a problem. It will increase the prevalence of obesity and also will make diabetes difficult to control because the post-prandial blood glucose level will be higher, and also it will help in encouraging the fat deposition in the fat cell. It is recommended that the carbohydrates to be of low glycemic index. As I mentioned before, low glycemic index carbohydrate from meta-analysis showed reduction in the A1C by around 0.4%. What about fat? Again, we all agree now that quality of fat is more important than the quantity of fat. So it is safe to give 30 to 35% of the energy intake as fat. If you go slightly up, but mostly on monounsaturated fat and polyunsaturated fat, I think it's still safe. And we have to remember that older generation used to give more fat. They were around 40% fat, and it was not as problem as we think it was. What about saturated fat? Definitely saturated fat should be around 10% or even lower. But also if you substitute saturated fat for polyunsaturated fat, you give more polyunsaturated fat and less saturated fat, it will be better. But you have to remember that the source of saturated fat is also very important. Saturated fat from meat and processed meat is linked directly to coronary artery disease. But saturated fat from dairy products, milk and cheese and yogurt, this is not related to increase the prevalence of coronary artery disease. What about cholesterol? The general recommendation is to reduce the cholesterol intake. But you have to remember that the ratio of saturated fat to polyunsaturated fat in combination with cholesterol is the modifier of the impact of dietary cholesterol on LDL. So if you are eating more POFA, that saturated fat, in combination with the cholesterol has less impact. If you are eating more saturated fat than POFA with the cholesterol will have more impact on the LDL. What about protein? We have an agreement from the previous webinar that we should calculate the protein as gram per kilogram, not as percentage. And the risk in that scenario is that if we calculate it as percentage, you are always at risk for low protein intake if you reduce the caloric intake down. So people on 1,200 calorie diet, 1,000 calorie diet, 1,500 calorie diet will end up with lower protein intake if they fix the percentage around 15 to 20%. So maybe you will go up on the protein a little bit more, and there is data now to show that if you go up to 30%, A1C is down in 5 weeks by 0.8%. There is more weight loss. There is more reduction in the LDL, especially if protein is combined with low glycemic index carbohydrates. One additional advantage of protein with low glycemic index carbohydrates is the maintenance of weight loss after people initially lose weight. Fiber. We need to increase the fiber. Although the recommendation now is around 25 grams of fiber per day, try to aim for a higher fiber is tolerated. And I will show you that some associations are actually recommending significantly higher fiber. Again, we have to remember that fiber comes from different sources. There is soluble fibers, which has a huge impact on LDL. And then you have insoluble fiber, which actually reduce the risk for cancer and regulate the gastrointestinal motility in a very good way. And finally, you cannot recommend any diet without exercise. Most people need 30 minutes per day of exercise at moderate intensity. I will say at least 5 days per week, even more. But if you would like to lose weight, you may need to increase that duration to around 300 minutes of exercise and maintain that 300 minutes of exercise. Exercise should be 3 types of exercise: flexibility exercise, like stretching and yoga; aerobic exercise, like walking, biking; and resistance exercise, which is very important for people with diabetes. Especially with the protein intake, you need to maintain muscle mass, and we'll explain this much more in the last webinar. I will go back and remind you that when we helped people with diabetes or pre-diabetes or at higher risk to develop diabetes to lose 7% of their body weight, insulin sensitivity improved by 57%. This is better than 1 or 2 medication for diabetes at their maximum dose. So if people lose, and especially if they lose weight from waistline, insulin sensitivity significantly improve. And as I mentioned, this has a huge impact on the endothelial function, which is the early stage of atherosclerosis. People with diabetes, if they are obese or if they have pre-diabetes, or if they don't have diabetes or pre-diabetes but just obese and insulin resistant, they have endothelial dysfunction exactly at the same level. So it is not that you wait until you develop diabetes to develop atherosclerosis. You can develop atherosclerosis just by being overweight and insulin resistant. When people lose weight, as you can see, endothelial function improved by 80% in every single group of those people who we evaluated 11 years ago. Again, we know why the improvement occurs. And if we measure the pro-inflammatory cytokines, the cytokines that cause inflammation, and most of them originated from visceral fat, the intra-abdominal fat, we see them going down from 15 to around 25%. Risk for heart attack, as shown here by the plasminogen activator inhibitor 1, is significantly down. CRP, TNF-alpha, IL-6, and adiponectin. Adiponectin goes up, although in this study it was not significantly up, but in other studies with weight loss it was even higher and significantly different than control group. As you know, adiponectin improves insulin sensitivity. So let us see what we had learned from prevention trials. So the most important trial is the diabetes prevention program. In the diabetes prevention program, we took people who already have pre-diabetes, diagnosed the pre-diabetes, and then we implemented either lifestyle intervention to help them to lose weight or giving them metformin. And the study showed that lifestyle intervention reduced the conversion to diabetes by 58% in comparison to metformin, which reduced the conversion to diabetes over this period of time by 31%, which means that weight loss is definitely very important. In the continuation of the observation of the diabetes prevention program, which is called Diabetes Prevention Outcome Study, the same reduction is continued between lifestyle and metformin in comparison to placebo. Recently, 15 years of data had been published and showed exactly the continuation of the prevention that occurred with lifestyle intervention, even if those people start to gain some weight back. Many clinical trials that had been done either using dietary intervention or exercise intervention or diet and exercise, like the Dashing study in China, the diabetes prevention program, the Finish study. All those studies are in favor of the lifestyle. So the hazard ratio is significantly down. And collectively, those studies showed in one meta-analysis that there is a reduction of around 49% in the risk of developing diabetes by weight loss and implementing nutrition therapy and exercise. What is the impact on A1C? In two nicely randomized clinical trials, we have seen reduction of the A1C by around 1 to 2% in patients with type 2 diabetes. So medical nutrition therapy, in reality, if we use it based on the clinical practice guidelines, CPG, medical nutrition therapy, as you can see in this slide, there is a reduction of the A1C from 8.3 down to 7.4 in one study, from 9.2 to 8.2 in another study. But there is more than 10 studies that had been done using medical nutrition therapy showing significant reduction in the A1C. Recently, Sylvia Lee, Viswanathan Mohan, and Frank Hu, and myself published a very nice review article in Lancet. The title of the article, which is one of a series of two, about prevention and management of type 2 diabetes, and explaining the nutrition strategy and the dietary components that should be used in that purpose of prevention and management of type 2 diabetes. I will appreciate if you'll go back and print that study and read it carefully. But I will highlight from this study several observations from observational studies, from meta-analysis, and also from randomized clinical trial. The first one about the prevention of diabetes. And you can see, if you would like to prevent diabetes, you will find that many of the components of dietary intervention had been linked to increase risk for diabetes. Like, for example, heme iron. Heme iron has the highest increase in the risk for type 2 diabetes. If you increase the glycemic index, you eat carbohydrates with higher glycemic index, refined and highly processed grains, or sugar, the risk for type 2 diabetes is significantly higher. Similarly, if you increase the carbohydrates, if the carbohydrate load, and you can see this in 17 different cohorts, there is significant increase in the risk for type 2 diabetes. On the other side, magnesium, vitamin D, cereal fiber, especially oat fiber, are associated with a reduction in the risk for type 2 diabetes. Even among fiber from fruits has a little bit lower risk than fibers from vegetables, which is slightly increased risk. But in general, the load of fiber is very, very important in all scenarios. The second graph that I would like to share with you is related to some of the food that we consume as well in relation to the risk for type 2 diabetes. And as I mentioned in the second and third webinar, meat, which is processed or unprocessed, has the highest risk for type 2 diabetes. Interestingly, also seafood, especially seafood in Europe and in North America, while fish and seafood in China and Asia has actually shown to be associated with a reduction in the risk. We don't know the reason, but it could be the type of fish or the cooking method, or maybe the pollution in relation to the fish farming. White rice also had been associated with increased risk for type 2 diabetes. But on the other side, green leafy vegetables tested in many cohorts in Europe and in the North America showed reduction in the risk for diabetes. Dairy products, and we mentioned before that saturated fat even from dairy products has no link to coronary artery disease. In reality, dairy products, especially yogurt, had been associated with a reduction in the risk for type 2 diabetes. Whole grains, and we mentioned it before, every time you add more fiber, so whole grains have more fiber, it is less processed, and the risk for diabetes is significantly lower. The same you will see with beverages. Sweetened beverages has higher risk, but decaffeinated coffee and tea and coffee has been shown to be associated with reduced risk for diabetes. I know people love coffee at night, they drink decaffeinated coffee. So be assured that those are beneficial. They can reduce the risk for diabetes. Alcohol, the relationship with alcohol is U-shaped. At certain level of alcohol, you get prevention from diabetes. But if the alcohol goes up that range, you will see increase in the risk for diabetes. So consumption of alcohol around 20 grams per day for men and 24 grams per day for women is actually the optimal amount. Going above that will have increased risk of type 2 diabetes. So what about the dietary pattern? And dietary patterns are very important because many ethnic groups share the same dietary pattern. So for example, Mediterranean diet had been tested a lot for prevention and management of diabetes. Data showed that people who use the Mediterranean diet have much less risk of type 2 diabetes. This had been shown in meta-analysis, in randomized clinical trial. It had been very, very clear that Mediterranean diet has impact. Mediterranean diet, if you go back to what we mentioned about macronutrients, it has more olive oil, it has monounsaturated fat, it has less meat. So again, this looks like a good diet. And imitation of this Mediterranean diet can be of very good value, not only for prevention of diabetes, but also for management of diabetes and prevention of coronary artery disease. DASH diet, which is low in sodium, higher in vegetable and fruits. Again, this diet had been shown to associated with a reduction in the risk for diabetes. But also if the salt is reduced to around 2,400 milligrams of sodium per day, it has benefit in glycemic control and prevention of coronary artery disease. What about vegetarian diets? Definitely vegetarian diets had been shown to be associated with reduction in the risk for type 2 diabetes. But for management of diabetes, there is a lot of controversy here. And part of the controversy here is that most of those diets that had been studied with vegetarians had been also low in calories. So there is caloric restriction. So if you have caloric restriction, and vegetarian definitely will get some benefit. But if you don't have caloric restriction, the carbohydrates is still significantly high. There are several other eating patterns, like for example, the use of the alternative healthy eating index. In this index, you rate the food that you eat in relation to the quality of the food. Again, this is an early work, but it showed very nice reduction in type 2 diabetes, especially in people who get adherent to this dietary plan. The prudent pattern is a pattern of eating is also very low in refined grains and sugar and sweetened beverages and lower in meat. Again, it had been shown to reduce the risk of type 2 diabetes, but we don't have any data so far about the management of diabetes. What about people who reduce carbohydrates and increase fat? Again, it depends on what type of fat. If the fat is of plant origin, there is always a reduction in the risk for type 2 diabetes. But if you reduce the carbohydrates and increase the fat, but the fat and the protein is from animal source, then the risk for type 2 diabetes are actually high. Again, the same way for management of diabetes, every time you reduce carbohydrates, as we mentioned before, you will see always an impact on the blood glucose level, and this will help in glycemic control. In general, if you look to those eating patterns, there is one theme going on in that eating pattern in general. What is that theme is? Lower refined carbohydrates, lower meat and processed meat, and in the same time, there is more vegetables and fruits and monounsaturated fat from healthy sources like olive oil. So again, from every single evidence that we have so far, which I explained in the first 3 webinars, it looks like we know now what will have the best impact on prevention of diabetes and also in management of diabetes. But let me put this in summary here, but I will also focus on some particular type of food that had been shown in randomized clinical trials and in meta-analysis that it is associated with reduction in the risk for diabetes. The first in the list is the oat cereal. So we still encourage our patients to eat oat cereal. The higher fiber cereal had been associated with reduction in the risk for type 2 diabetes. Yogurt, as I mentioned, on the top of the dairy products, but in general, dairy products had been associated with reduction of the risk for type 2 diabetes. As I mentioned, tea, coffee, and even decaffeinated coffee, which means that it has nothing to do with the caffeine. It is related to the polyphenols. This beverage is associated with reduction in the risk for type 2 diabetes. Green leafy vegetables provide insoluble fiber, which reduces the absorption of carbohydrates. Fish and seafood only in Asia, not in Europe and North America. It is exactly the opposite. Certain fruits like grapes, apples, blueberries, again, in those cohort and observational trial, they were associated with reduction in the risk for type 2 diabetes. Nuts, and especially walnuts. Walnuts is associated, even people who think that walnuts and nuts in general, because they are dense in calories, will increase body weight. Actually, trials, especially in the Mediterranean area, showed that people who are consuming a higher amount of nuts, they actually losing weight. So they are not gaining weight as we initially thought of. And as I mentioned, alcohol has a U-shaped, was optimal around 24 grams for women and 22 grams for men. Going up on the alcohol will increase the risk for type 2 diabetes. Eating pattern, Mediterranean diet, DASH diet, vegetarian and vegan diet, prudent pattern, moderate low carbohydrate and high plant-based protein and fat. Again, all of those eating patterns have been associated with reduced risk for type 2 diabetes. Finally, let me end up with a current recommendation of 3 different societies: the American Diabetes Association, the Canadian Diabetes Association, and finally, the Diabetes and Nutrition Study Group of the European Association for the Study of Diabetes. And the reason for making that comparison here is to show you there is a lot of differences between them. And these differences sometimes are in favor of the recommendation that we mentioned, and sometimes they are lacking behind and they didn't implement the recent data that we have from meta-analysis and the randomized clinical trial over the last few years. So they all agree on weight reduction. They all agree on reducing caloric intake. But when it comes to macronutrient ratio, the American Diabetes Association recently didn't specify any certain percentage because they thought that evidence suggests no ideal distribution for all people. So there is no one size fits everyone. But still, the Canadian Diabetes Association and the European group recommending higher carbohydrates, 45 to 60%. They are still recommending lower protein between 10 to 20%. So I think this, based on the new evidence, need to change. I think if we keep feeding our patients with high carbohydrates, it will be a problem. And as I showed in the meta-analysis, increasing glycemic load was associated with increased risk for type 2 diabetes. About dietary eating pattern, again, there is agreement about the dietary eating patterns. Although the European has no specific recommendation, but again, Mediterranean diet, DASH diet, I think we should agree all that this dietary pattern is beneficial. What about glycemic index and glycemic load? Only the American Diabetes Association and the Canadian Diabetes Association are stressing on using the glycemic index. Although still the American Diabetes Association are saying substituting low glycemic index for higher glycemic index may be beneficial. I think it should be beneficial. We shouldn't say may be beneficial. There is data to show for sure that low glycemic index reduce postprandial blood glucose level and reduce A1C by 0.4 in average in the meta-analysis. The Canadian are more strict and they recommend using carbohydrates of low glycemic index. The European group recommend the low glycemic index, but they make it just a fluid recommendation in substitution of the carbohydrate-rich choices. I think, again, this part need maybe adjustment in the future based on the clinical data. Regarding the dietary fiber and whole grains, still the American Diabetes Association recommending around 25 grams of fiber for people with diabetes and people without diabetes, or approximately around 40 grams per 1,000 calories. Although they recommend for men to go a little bit up on fiber to 38 grams per day. In comparison, the Canadian Diabetes Association recommend more fiber. They recommend between 15 to 25 grams of fiber per 1,000 calories, up to 50. The European group also recommend higher fiber, around 20 grams per 1,000 calories. And they actually are more specific. They need half of that fiber to be soluble fibers and half of that fiber to be insoluble fibers. I think definitely there is data to show that if you increase the fiber up and if you can reach 50 grams of fiber per day, if tolerated, the glycemic level will be much lower, even if you consume higher carbohydrate load. Regarding sucrose and fructose, I think there is always agreement that we should limit intake of sugar-sweetened beverages. The Canadian and the European said there's no more than 10%. I think if we lower even than that number, it will be better. What about protein? Still here, big controversy about protein. The American Diabetes Association don't have any specific recommendation, but they departed from that old concept that you need to reduce protein to preserve the kidney. Now, they said it is not recommended to reduce protein intake in people with diabetes and kidney disease. So this is a new update, which I think it makes a lot of sense. The Canadian and the European are still recommending lower protein intake, around 0.8 gram per kilogram for people with diabetes and kidney disease. European, although they recommend the lower protein, they said there is insufficient evidence to recommend the protein restriction. If we move to fat, then you will see the controversy is even higher. The American Diabetes Association, in their last recommendation, they recommend MOFA. And I think this is a fantastic recommendation because we know that MOFA reduces the LDL and increase HDL more than any other type of fat. The Canadian are recommending 20% from MOFA and 10% from POFA, which will leave you with another maybe 10% of saturated fat. So basically, it looks like they are up to the 40% of fat. The European are having the same recommendation, 10 to 20% from MOFA and 10% from POFA. Regarding the omega-3, again, the three of them agreed that there is no data to support adding omega-3 as supplement. Regarding saturated fat, the recommendation is to reduce the saturated fat less than 10% and the cholesterol less than 300 milligram per day. The Canadian is even more strict, less than 7% from saturated fat. The European is recommending less than 10% and less than 8 if the LDL is high. Again, there is no mention of the type of the saturated fat. There is no mention of the ratio of polyunsaturated to saturated fat in combination with the cholesterol. I think these are enhancements that need to be added in the future. About macronutrient supplement, there is no recommendation, which I think it is sound recommendation. There is no evidence, although vitamin D and magnesium had been shown to reduce the risk for type 2 diabetes. Again, the alcohol, I think the major issue is about weight gain and hypoglycemia. We are now in clear view that the relationship between alcohol and diabetes is a U-shaped curve, and there is an optimal amount and there is a harmful amount of alcohol, and we need to stick with the optimal or less. Finally, sodium. Restriction of sodium has been also significantly variable. In the American Diabetes Association, they recommend no more than 2,300 milligrams of sodium per day. And even in some people, a restriction can be even more. In the Canadian, there is no specific cutoff recommended for people with type 2 diabetes. I don't know why. In European, they restrict salt intake to under 6 grams. I think the upper limit is still significantly high. Neither the American Diabetes Association or the American Heart Association or the American Society of Hypertension are recommending that much salt. So the take-home message from this presentation is that medical nutrition therapy is very important for prevention and management of type 2 diabetes. We all agree that weight loss, 7% weight loss, 5 to 10% weight loss, I will say, improve insulin sensitivity and reduce risk for cardiovascular disease. Certain food and dietary pattern, and we mentioned that Mediterranean diet, DASH diet, vegetarian diet, especially with plant origin fat and protein, all of them are associated with reduced risk for type 2 diabetes. Medical societies are still very significantly in the recommendation of medical nutrition therapy. I think there is a need to enhance this evidence-based clinical guidelines by a lot of new information that we gathered over the last few years from randomized clinical trial and meta-analysis. In the upcoming last webinar, we will discuss, can we implement very good and successful weight loss in clinical practice? Can we achieve long-term weight loss in clinical practice or not? I think this is a very important point, and we need to agree on how we can do this management, how we can help our patients to live healthy, long life by losing weight and maintaining that weight loss. What is the dietary plan that we should use if we would like to help people to lose weight and control diabetes in a much better way? What is the type and the duration of exercise that has the most impact on body weight in patients with diabetes? Most people don't know that different types of exercise have different impact on body weight and on glycemic control. Do we need short bouts of exercise, 10 minutes, or we need longer bouts of exercise? Do we need moderate intensity exercise, or we need extensive type of exercise? Which one is beneficial? Which one improve compliance? Which one improve weight loss? Can we adjust the diabetes medication for an optimal weight loss? We know that many of the diabetes medication cause significant amount of weight gain. So those medications need adjustment, but we need to be very creative in adjusting those medications so as not to compromise the diabetes control. And then finally, which intervention is cost effective? What is the impact on healthcare cost? This is the bottom line. The healthcare cost. You know, the cost of diabetes is significantly high, $245 billion. Do we have to go and recommend the non-surgical weight management, or we go and recommend the bariatric surgery? Then we will answer this because it is very, very important and has a huge impact on our clinical practice. With this, thank you very much for your good listening.